So let me welcome Ambassador Deborah Birx to give the next plenary, Seizing an Historic Opportunity, a response based on sound science and fundamental human rights. Debbie.
I almost missed my cue. Thank you. Oh, great. Thank you for the slides. Thank you for coming back from coffee. And we're going to go quickly because this is information that you all know well, but really I wanted you to hear my interpretation of the data that we've had to date. And you all know the history of the pandemic, but I think it's important to remind people at this moment in time about the progress, but what Michelle talks about as people left behind, but also the economic burden of HIV/AIDS, because we have to learn how to talk to ministers of finance in a way that's compelling, and we haven't always done that. So I think we have to go back to the early data and show the impact that HIV/AIDS had on the most productive years of the 25 to 50-year-old age group, and show what impact that had on the productivity and how that has been returned. I think just like we were slow as a global community to recognize the depth and breadth of this Ebola pandemic, we were slow in recognizing the global nature of HIV/AIDS. And this is my one opportunity where you will hear me not talk about country ownership. And I think the reason I don't use that terminology is not because it's not appropriate terminology, but when I was privileged to work in both Asia and sub-Saharan Africa before PEPFAR and the Global Fund. And I can tell you that every country I worked in had a strategic plan and owned their pandemic and knew how devastating it was and knew how crushing it was to the teachers, the nurses, the doctors, and the communities affected by HIV, but did not have the resources to combat it. So this is not an epidemic that wasn't owned by countries. It was an epidemic that was owned by countries, but without the resources to implement their response. So President Obama is deeply committed to an AIDS-free generation, which is, when you break it down as someone did earlier today, it means making sure that no baby's born with HIV, but making sure that that baby grows up happy and healthy and makes life choices that keep them free of HIV, including young women. So there's a continuum of work that we have to do, and we've been working very hard on pieces of the continuum, but not in a comprehensive way, in a way that was going to really control the pandemic. And so we've made unprecedented progress under President Obama of a program that was started under the leadership of President Bush. And this is really historic in the United States, to have legacy programs continued, expanded by another administration. And this is really, I think, shows the depths of support for PEPFAR, both at the congressional level and at the administrative level. So we all know that the impact HIV/AIDS had on life expectancy and how that return has occurred because of the partnership between the donors and countries and the leadership of UNAIDS to really get us focused and motivated to do something. And I think you've heard about the decreasing incidence of new infections, particularly in the large Blue Mountain part, which is sub-Saharan Africa, and from the peak of the epidemic, really halving the number of new infections. But you can see also that same type of halving occurring in the Caribbean. There are other areas where we have not had a significant response, and you look at Eastern Europe and Central Asia, the yellow line, it's very much persistent. But the progress that we just discussed is not equal between all countries. And so this was the reason it has to be a very country-analyzed, data-driven analysis so that we really understand the difference between... It's on. The little green light is on. Someone do something. It's not me. Okay, something horrible has happened. Way back. Okay, I will speak in my normal command voice. This is the advantage of having been active duty military. But you can see that everything is not equal, and hopefully they'll get this fixed, and then I'll be shouting. You think that's working? Okay. This one sounds like, oh, is it working again? Can people, oh, okay, look, we've made progress. Maybe it's not high enough. That's a backup. Okay, maybe I'm too tall. Let's try something else. Okay, is that better? Can people hear that better? Okay, so the progress is not equal. And I think when the call to action, when the Uganda data came out, and this is just really my important plug again to the absolutely importance of UNAIDS and their report. They always have had the data online, and they always do these fantastic reports. But I think this last GAP report was so clear, and the graphics so interpretable that you didn't have to read all the words. You could have flipped through the GAP report and gotten a really incredible sense of where the epidemic is and what needs to be done. So I just want to thank UNAIDS again for really that leadership there. But you can see that progress is not equal across all of the countries. And so we have to really look very specifically at every country and try to understand the differences. So if you compare Malawi, and it's great to have the Ministry of Health here from Malawi, and the bold vision that Malawi has had from the beginning to really bring comprehensive services to their population, all of their population. And you can see what an impact that scaling of services has had on the pandemic in Malawi. And so there's been this dramatic decline in both deaths and new infections in Malawi. If you compare that to Mozambique, you see a stark difference. And the reason I show these two side by side is because no one can say, well, Malawi had so many more healthcare providers than Mozambique, or Malawi had so many more sophisticated health facilities than Mozambique, or they had more nurses, they had more doctors, they had community health workers. No. It's very much equal between Malawi and Mozambique, and you can see what leadership in country and focusing of resources can have in their national strategy and the impact it can have on the pandemic. So we know what is possible, but we're not reaching every country and every population in the same way. You look at West Africa, and I think West Africa suffers under the fact that they've never had a raging epidemic. The prevalence has always been between 1% and 4% in a whole series of countries. So it didn't have the same raising of awareness, and I think the more of an emergency to this pandemic. You can see in both Nigeria and Cameroon, we have not significantly stemmed the tide in both new infections or deaths. And this is the Uganda and Kenya picture, and again, very similar epidemics. And Uganda had a magnificent response in the the mid-90s. And then an increase in the number of new infections. And this is a wake-up call to every one of us that says we can never take the eye off the ball. While we're achieving, we have to continue to accelerate our achievement, or it's the potential for new infections to rise again. So I like to sometimes present counterfactuals. So the blue line is where we would have been if we hadn't had the leadership in country and the financial resources to support that leadership. And we are now on that orange line, and this is the number of HIV/AIDS deaths. And we're now on the blue line of the number of new infections, and it shows you where we would have been in that double peak that we would have had in the epidemic, and the fact that we avoided that by these comprehensive interventions. But I really love this new graphic that was in the GAP report, and what it says is if we don't, we're on the blue line right now, if we just continue as we have, at the rate that we have, we end up on the blue line. That results in additional $8 billion in treatment costs per year by 2020, and another $31 billion per year every year after 2030. We can be on the green line, which is a line that is cost-effective, which is a line that takes us to control of the pandemic. But that's going to require a focus from all of us on really ensuring that every resource is targeted. So how do we deliver an AIDS-free generation, and how do we focus the PEPFAR dollars to support national strategies? And as I mentioned, we call this the right things in the right places at the right time. And again, we've been given the right things, and we are privileged to have that knowledge, the scientific knowledge of what those are, and we know it as combination prevention, and we know about effective targeted prevention. We're getting more knowledge about healthy children out of our Orphans and Vulnerable Children's program. And we know the neglected and hard-to-reach populations, thanks to the GAP report, are centered on pediatrics, young women, and key populations. We actually know what elements of the health system are actually absolutely critical to be strengthened in order to achieve our goals. So what are those right things? As mentioned, we've been meeting with countries to really get countries to focus on what are those core activities that we know to be the right things. And what are the near core activities that support the implementation of the right things, and what are the non-core activities? This is what Uganda was able to do, and this is what brings me incredible hope of what is possible. In a level budget scenario, and that's in the blue bars, Uganda was able to double the number of people receiving treatment. They were able to implement B+, shown in the light purple, and almost double the number of women tested within a 24-month period by refocusing where they were working and how they were working. So we went through those light purple bars of access to ART of B+, and a dramatic 10x increase. And this is what happened with voluntary medical male circumcision. So Uganda shows us that this kind of refocusing and prioritizing can occur, and the results are incredible. What do I mean by right places? And it means going to the highest burden countries, and within those countries, the highest burden districts, to ensure that everyone in those areas have access to services, to meet the unmet need in these facilities. I think you heard that in many cases, 80 to 90% of the patients are in 15 to 20% of the facilities. This is a way that we have to really ensure that our human capacity, which is our most valuable resource throughout the world, that our human capacity is focused in the area where there's patients. This is an example of Tanzania and the data that they have at the subnational level. And you can see that there's areas of very low prevalence and there's areas of high prevalence. So there's provincial level prevalence of 1.5 all the way up to 14.8, you can see with one of the stars. If you then translate that into burden of disease by population base, you end up with those red swatches and orange swatches, which very much correspond to prevalence. But then if you look across the country of where we have invested our resources, and this is just PMT-CT testing, you can see that 32% of our 5,309 sites, 32% had no HIV positives over a 6-month period. And then we had a large number of sites, 55% of the sites, which had very low yields. And 13% of the clinics were seeing 70% of the patients. Now, what does this look like in a histogram graphic? So this is all of their PMT-CT positives over the last 6 months divided by sites. And you can see that out of these almost 2,200 sites, 1,400 of these sites had either 0, 1, or 2 positive patients in a 12-month period. What do I mean by the right time? The right time means right now implementing the new WHO guidance. You've heard of countries who have been unable to make that switch between 350 and 500. You've heard from countries that want to have universal access to treatment through test and treat. You've heard of countries that want to roll out a B+ and haven't had the resources. So we have to ensure that we move from the areas where we have not found HIV to the areas where there is HIV to ensure that we can deliver those services. I just want to have one comment on quality because you all recognize how important it is. But we lose all of our progress if we don't have adherence. And we know the keys to adherence are community-level programs. But again, those community-level programs need to be where there's HIV patients. So we have to look very carefully at the community level through this testing data of where there is HIV and where we need to strengthen community-level services. We lose 50% of the impact of our combination prevention and our ART if we have 50% less adherence. Now that makes sense on paper, but we're not focusing our programs that way to ensure that we don't have that loss to follow-up in that same way. And you can see this incredible contribution to deaths and how it increased dramatically if adherence declines. Now, these models have all been done for Kenya, and this shows we're currently on that orange line and could be on the blue line, and you can see the contribution to ART. ART alone accounts for 76% of the infections averted, voluntary medical male circumcision 10%, condoms 4%, and prevention of mother-to-child transmission 10%. So we've launched this interagency collaborative. It was launched by Secretary Kerry to bring the agencies together in real time in the same place where they can share data and analyze the site-level quality data that we've just been launching, look at the expenditure analysis data and the results, but all at the site level. Now, we know that part of our responsibility is also to make that data available to the scientific community, governmental leaders, and all of our data right now from the first 11 years of PEPFAR is on pepfar.gov if you go to data and results. It's not perfect because we've just, we've scrambled to get all of our information up there, but all of these new data will be posted as the data is developed and made available. So this quality improvement strategy has the U.S. government teams working with the host country partners to go to every site and look at the quality of the services that are being implemented. CDC has done this over the past 24 months, and this is 3,500 sites that were visited. And you can see it's a simple color-coded spectrum where every site before you leave the site understands where they need urgent improvement, needs improvement, meets expectations or exceeds expectations. And not all areas are the same. You can see there's some more difficulty. 50% of the laboratories need improvement or require urgent remediation. And you can see that with voluntary medical male circumcision, it's half that. So we're looking at how we're doing programming and how we're supporting programming to understand how voluntary medical male circumcision has done so much of a better job. And the reason they did is they required monthly site reporting where they could really intervene in issues quickly. Leaving no one behind, and again, highlighting the UNAIDS report. This graphic is incredibly important to me personally because it says the different areas of the world and what the most vulnerable populations are. This is particularly critical now in sub-Saharan Africa to raise the awareness of young women, and that dark blue circle is young women. And all of the other circles, the MSM, transgender, prison populations, sex workers, all of those other dots, essentially their volume will fit within the young women's volume. So in each of these areas, we have to know what our vulnerable populations are and make sure that we have programs targeted for them. And this is the discrepancy of the actual number of new infections in young women 15 to 24. With that level of new infections in between 15 and 24, it means we have to reach young women before the age of 15. And this is their breakdown, again, from the global report on each country and the difference between young women and young men. And you can see in every country, although the prevalences are different, it's always twice that of young men. It tells us that most of the young women are not being infected by the young men, and the young men are not being infected by the young women. So we have to figure this out and figure out how this is happening. Now, we know part of it is violence and gender-based violence, and we've been supporting through Together for Girls, which is with a UNAIDS secretariat, to really look at where there is gender-based violence, and this is the percentage of females between 18 and 24 who report unwilling first sexual intercourse before the age of 18. These numbers are extraordinarily high. They have resulted in legal and policy changes within countries. But if it doesn't change the community's view of this, all of the legal and policy changes will not have an impact. And again, it gets back to this dialogue with the community and dialogue about social norms at the community levels and how they're going to implement these changes. This is the burden of disease in sex workers, and you can see in each case in sub-Saharan Africa, the burden of disease is much higher than the general population. The same with transgender women. Most of our data, this really points out also that we don't have good data everywhere. So a lot of this data comes from the developed world. This is the data of men who have sex with men disproportionately bearing the burden of disease in all of the countries that we're reporting. This data is critical. I just was at an IHV meeting, the University of Maryland Bob Gallo meeting, and they reported on data out of Nigeria. And they were able to launch a large MSM analysis and cohort before the law and be able to show how the laws in Nigeria impacted access to services. So they're one of the few groups that were enrolling MSMs at the time that the discriminatory laws were instituted and the impact that that had. But in Abuja, in that analysis, it was very interesting that 66% of the MSM group reported primarily bisexual behavior. And the prevalence among MSMs that they recorded was 45%. So although our on record is 14%, we have underestimated the prevalence in some of these populations. And that leads to me what was discussed earlier, the discriminatory cultural and legal frameworks in which we all are trying to work and all trying to reach vulnerable populations. And you can see by the colored map, except for South Africa, most of sub-Saharan Africa has known discriminatory laws on their books that are now, some are choosing to enforce, and others have passed additional new stringent legal frameworks that require reporting or make it so anyone can't assemble or provide services. Because if you're providing a clinic to MSM, that could be interpreted as assembling MSM. So there's a lot of fear among partners about what will happen to their clinics and their outreach. In an analysis from Chris Beyer of the impact of these discriminatory cultures, even before the legal framework or enforcing the legal framework, this is just discriminatory practices within the public health service community. Many of them felt that they were unable to seek health services, that they were afraid to walk in their communities, that they had been blackmailed or they had been beat up at multiple times. Finally, as brought up by our colleague about issues of people who inject drugs. And you can see that there's a vast difference between Europe and others in the response to access to ART. So you can see the volume in Europe where more than half have access to ART. But then if you look, more than half carry the burden of disease, but less than half have access to ART. So even though we are testing patients and we know their serostatus and they know their serostatus, they're not being able to access comprehensive services. We had and still support large numbers of programs in the Ukraine, but a lot of those programs to deliver MAT and to deliver ART were supported and primarily in eastern Ukraine. No one's been able to see how those services have been provided. We do know that many of those patients have made their way to Kiev, but they have not had access to services beyond individual groups taking on additional patients, which many have, but they don't have the resources to maintain this. And so we all have to be sensitive to the shifting needs when we have these crises and have funds available to meet that need. So this is just to summarize once again. We know what the right things are. But together, do we have the political will to ensure that they're implemented? And this really comes to the leadership in country and the parliamentarian leadership to really ensure that we focus our resources where there's HIV, including make sure they're in the right places, and that we're reaching the vulnerable populations, including young women, and ensuring that we have the right combination of interventions that are specifically address the unique challenges that young women face. And then to ensure that collectively we're implementing the WHO guidelines. We're out 18 months almost from their release, and there are countries that have not been able to implement them, not because of the will, but because they've not had the finances in order to fully implement. So what is our specific vision? It's very straightforward in that we're trying to raise our personal accountability by adding a large portion of our work in a transparent environment on our website so that anyone can access it. Ministers of health, NGOs, advocates, activists, and including people in Iowa of the United States can look at what this program is doing and how we're doing it. And then we've launched a large impact initiative where we're working country by country in partnership with the ministries of health to really analyze the impact of these programs with these AIDS impact assessment. You may have heard of them as AIDS indicator surveys. They have been done in Kenya, Uganda, Tanzania. Botswana has always conducted one financially funded by the ministries of health from Botswana. And it's to look at what evidence do we have that we are making progress. We have excellent models, but I think it's also incumbent on all of us to ensure that we validated the models and we actually have documented evidence from incidence and prevalence. And then finally, these are our agenda pieces. So we have the impact agenda that we just talked about and finding the scientific evidence that we are actually winning and creating an AIDS-free generation. Our efficiency agenda, which is very much focused on our expenditure analysis and understanding the cost of performing services at the site level, the results at the site level, and the quality of those results at the site level, and integrating those three pieces together to look for our optimal programming. The sustainability agenda, bringing along the work that Ambassador Gooseby started, from the partnership frameworks to these new country health partnerships, and ensuring that we're in lockstep with governments. Many governments are ahead of us now, like Kenya, who just published this new approach to how to really control the pandemic. We have to make sure that we can be there to implement what the Minister of Health from Swaziland wants, what the Minister of Health from Malawi wants, because that's where the sustainability comes from. And then working with ministries of finance over time to really start talking about success and middle income status and what that means and how these programs will be funded in the future. Our partnership agenda, we have 4 key leaders now appointed for each of these agenda items. The partnership agenda is now under the leadership of Kaya Lewis. She will be working very closely with UNAIDS, WHO, the World Bank, and all of our ministers of health and our advocates and activists to really ensure that we are in partnership in the optimum way to combine our resources with others' resources for the maximum impact. And part of that is the transparency. They have to know exactly where PEPFAR is and what PEPFAR is doing in order to support the larger vision and integration with the Global Fund resources. And then finally, the human rights agenda. We've been in the midst of recruiting very important individuals to run this item. We have also recruited additional 5 staff to work on this issue to ensure that we're working in every possible way to make sure that every single person who's at risk for HIV knows their risk, knows how to prevent infection, and if they get infected, have optimal services that are available to meet their need without stigma and discrimination. We have all and discriminatory laws passed that really influence the ability to deliver services and make our work accessible to all has been very disappointing to me and I think many in the audience. So just, wow, this microphone problem, a little bit of a deal. But I just wanted to end with these numbers because I know that we're very taken by epidemics around the globe. But we have to remind people about the work that is left to be done. Yes, we are 50% there. We've invested $50 billion. But that whole $50 billion is at risk if we don't figure out how to get on that green line together. Because there's not another $31 billion per year. No one can find that amount of money. No ministry, no Minister of Finance, no PEPFAR, no Gates Foundation, no Global Fund. So together we have to figure out how to get on the green line. Because this week, that we're now in the middle of and towards the end, 4,600 babies were infected and 36,000 adults. These are just the sub-Saharan Africa numbers. 3,600 children died this week because we couldn't get treatment to them when they were under 2 and not diagnosed. And 25,000 adults died this week. I hope that puts it in perspective of all of these other pandemics that we talk about. 25,000 adults dying this week. And yet there's a complacency that HIV is that old story that is finished. Please remind everyone, remind your leaders that we are not finished, and we have to ensure that we get onto the green line, or all of our collective investments, which could be in now the $100 billion range, will have been lost. Thank you.